Good morning, everyone. Welcome back to another academic session. Always a pleasure seeing you all. Today's lecture is on frailty in clinical practice, and it's conducted by Dr. Sithira Senevirathne. It's my privilege to introduce the first specialist in geriatrics medicine in Sri Lanka. Dr. Sithira is the acting consultant geriatrician in National Hospital Sri Lanka. He graduated from Faculty of Medicine, University of Colombo, and was the former fellow in geriatric medicine in Oxford University Hospitals. And his main interests include orthogeriatrics, geriatric palliative, and end-of-life care. So let's give it up to Dr. Sithira to conduct the lecture. Thank you.
Thank you very much, Ranesh, for that very generous introduction. And thank you very much, GMA, for providing this great opportunity to talk to a huge number of doctors to discuss this very important topic, frailty. And just before going to a deep dive in frailty, I wanted to highlight a few figures. So, did you know that world population is aging at the moment? So, if you look at the number of older people living today, so we have today the number equivalent to 2/3 of older people who have reached more than 60 years of age in human history. Really? That's a very large number of elderly people living today. And did you also know that Sri Lanka is one of the hotspots where we have the highest proportion of older adults in South Asia? And it's not even the proportion, so the proportion is also rising. So if you look at this chart, in 2003, we had only about 8% of people who are more than 60 years of age, but it's rising, and next year we are expecting for the proportion to rise up to 21%, and another 15%. One of every 4 people will be more than 60 years of age. So that's a quite rapid increase in older population. And also, if you look at the life expectancy at birth in Sri Lanka, so females, according to 2021 census, live about 79 years, while male lives about 73 years. So females tend to live longer than males. Yes. And so we would expect a lot of older women in future in your day-to-day practice. And it doesn't mean that we don't have people more than 79 years. In fact, if you look at the proportion of elderly between 70 to 80, 80 to 90, and 90 to 100, the group where patients are between 80 to 90 are the group that's exponentially rising. Mm-hmm. So we call this group octogenarians. So we expect a lot of octogenarians and a lot of females in your clinical practice in next coming years. So let's move into a story without talking more about stats. All right. So this story is about a true patient, actually. So I have seen a similar patient recently. So we will call him Mr. Pereira. So Mr. Pereira is an 82-year-old retired school teacher who had a relatively active life after the retirement. And he comes to your general practice for routine follow-up of his medical comorbidity. So he's diagnosed with diabetes, high blood pressure, dyslipidemia, some prostate issues, and osteoarthritis. Right. Yeah. And during his routine follow-up, he reports that he's having reduced appetite and that he is losing some weight, not a large amount, about 2 kilograms over the last 6 months. And now he is feeling more tired. So do you find similar presentations in your day-to-day practice?
Yes, of course.
Yeah, I think it's quite a common presentation where people sometimes complain being exhausted and having loss of appetite, which go unnoticed. And also he reports some urinary urgency, but despite all these, he's independent. At the moment, he's able to do his all basic and advanced activities of daily living. Right, let's see what happens next. So 3 months later, Mr. Pereira developed a chest infection, and so he was given some oral antibiotics by the general practitioner. So what we would usually expect is with oral antibiotics, chest infection should be resolved. But Mrs. Pereira notes that after 2 days, Mr. Pereira is slightly confused and he's still febrile. So she decides to take him to the hospital. On admission, abbreviated mental test score is kind of a score which we use in acute setting to assess someone's cognition. Is very low. It's 5 out of 10. So we make a diagnosis, clinical diagnosis of acute delirium. And when you investigate him, so you see that he has high white cell count and high CRP, suggestive of an infection, so which is compatible with the history. So now the oral antibiotic course has not worked, so the clinician decided to give him some IV antibiotics. So after 5 days of treatment, CRP normalized. So, and Mr. Pereira was discharged. So, looks like a happy ending. Yeah. So let's see what happens at home. So after normalizing of CRP, usually we expect the infections to completely resolve, aren't we? Yeah. So even though the infection is settled, so Mr. Pereira is not back to normal. Yeah. So even at home, he spends most of his time in bed, and time to time he is still getting confused, and he is still wobbly on his feet, and now because he feels weak, he needs some help for his washing and dressing. So, and as you can remember, he has developed some urgency even before he had the chest infection. Now he had a dry cough after chest infection, and this urgency is getting worse, and he is getting time to time urinary incontinence. All right. Unfortunately, after 1 month of discharge, now he is still feeling a bit wobbly. Okay, and he runs to the washroom because he has this incontinence, and this result in a fall and right side hip fracture. Okay, right. So have you seen similar patients? Have you seen older people getting acute medical problems? You do the standard treatment, you give the standard antibiotics, you treat for the myocardial infarction, but even after completing the treatment, they are still not 100%. I hope you have seen similar patients during your internship, some part of your medical training, yeah, and maybe your relatives, yeah, maybe your parents, yeah. So if you look at the timeline, so this patient had a chest infection which was complicated by something called acute delirium. It's kind of a transitional confusion state, and he get admitted to the hospital and had a standard course of antibiotics and discharged from the hospital, but story didn't stop from there. So he became more independent for his activities, and he had ongoing confusion, and then finally he had another fall which resulted in a fracture neck of femur. All right. Okay. Compare this story with a different story of a similar incident where, like, a 23-year-old university student, right, get a chest infection probably from the same bug, all right? So you give him 5 days of oral antibiotics, but things settle. Probably he's doing his studies even with the infection, all right? So as you can see, these are two different trajectories, okay? Right. So what do you think the reason for these two different trajectories? Older person getting chest infection and young person getting chest infection, you're giving same antibiotic and CRP normalizes, but the younger person improves, but the older person doesn't. Is that due to old age? Is that due to frailty? Or is that due to multimorbidity? Well, I'm sure that old age and multimorbidity both have something to do with this trajectory, but this concept is called frailty. Okay, right. I'll explain this further. So frailty by definition is decreased physiological reserve and resilience. So as a result of this, these older people are very much vulnerable to stresses. So if you give a stressor, so they will fall down from where they are. Okay, I will explain this using this graph. Okay, so in this graph you can see from the x-axis the time, and the y-axis you can see the functional abilities. Okay, so if you look at the green line, so this is compatible with a fit older adult or a younger person where they get this acute insult and their functional level goes down, but still they are in the light blue zone, which is the independence. Okay, so still they are independent, they don't become dependent. all right? But with appropriate treatment, they go back to their normal independent level, okay? So problem solved. But with frail older person, what happens is, with the acute insult, your functional levels drastically goes down. It goes down from independence to dependence, okay? And it take a longer time for the recovery, okay? It take a longer time for recovery than a fit older person or a younger person. And if you look at the new baseline, that's slightly lower than the previous baseline. So sometimes even they don't go back to the original baseline, okay? Right. So they come to a new baseline, which is far more closer to being dependent, okay? Right. So this is due to frailty, okay? Now you might be thinking, so what are the physiological reasons for this type of pattern and this type of trajectory? So if some of you thought this is due to merely old age, okay? So if we think this is merely old age, if you look at the picture in the left side, it's Fauja Singh, who is 113 years young at the moment, and at 100 years he completed a 5-kilometer run in just 49 minutes. Okay, so in your right side is probably a gentleman in his 70s, 80s who need assistance for walking. Yes. So it's not merely old age, so it's due to something called frailty. All right, so just to again explain this concept of normal aging and accelerated aging. So a person in your right is undergoing accelerated aging, okay? So at some age, everyone reach this area of frailty, okay? Everyone can become frailty. But if you are multimorbid, having more deficits, malnutrition, and lack of exercise, you are more prone to accelerated aging. So you will reach this frailty and disability at a younger age, okay? All right. So I hope you are a little bit clear about this difficult concept of frailty. So as we go on, we'll discuss a little bit more about frailty. So this concept will be much clearer, okay? And frailty is also connected to comorbidity and disability, right? That doesn't mean all patients with comorbidities or disability are frail. So, but these three concepts are closely linked, all right? Right. So if you look at the pathophysiology of frailty, might not be very important in your clinical practice. I'm just highlighting if someone is wondering why this happens. So it's due to age-related changes in multiple physiological systems, primarily neuromuscular, neuroendocrine, and immunological systems. So there are a lot of researches going on at the moment to see what are the exact changes happening in a person who is getting old and frail, whether we can develop anything to reverse these the hormonal changes. So so this is just for your information, right? I think far more important is to see how to detect frailty, okay? So as I have already highlighted, now if you look at Mr. Pereira, looking at how his trajectory followed after his acute infection, you can diagnose frailty retrospectively, okay? But is that enough? Probably not. Yeah, probably not. So if we can detect frailty at an early stage, okay, we could have done something to reverse this trajectory, okay? That's why we are seeing how to detect frailty. So if you see an older person in your clinic, and this is about how to identify patients who might deteriorate with acute medical insult, okay? Right. Okay, so when you discuss about how to detect frailty, there are several models, okay? So this is one of the very popular model, diagnosing frailty based on an older person's phenotype, all right? So there's a research team, actually a person called Fried and the research team did some studies and they proposed this phenotypic model where features like weakness, slowness, low activity, feeling exhausted, and losing weight are characteristics of frailty. Right. All right. So if someone is having, they further said, if someone is having 3 or more of these criteria, we can diagnose frailty. Okay. Right. Okay. If someone is having, like, for example, feeling weak, feeling slow, and feeling exhausted, basically we can diagnose frailty. Okay, and someone who has 1 or 2 out of 5 probably is having pre-frailty. Okay, they categorize them as pre-frail. If you further look into how we can assess weakness, slowness, low activity, and so on. So they have proposed weakness to be measured by person's grip strength.
Right.
All right. So we use an instrument called dynamometer, which we usually don't use day-to-day clinical practice, which we can get a numerical value for your grip strength. But if someone is like complaining that they can't open a lid of a jar, all right, probably they might be having reduced grip strength, all right, and feeling slow. And so they suggested several assessment methods, and low level of physical activity and exhaustion. There are standard questionnaires, and so there are some definitions regarding weight loss as well, all right. So I just wanted to highlight, but if you find a patient with weakness slowness, you don't have to numerically measure these values, but you can suspect frailty by just looking at their phenotype. Okay. So this is a very complex slide, so I don't expect you to go through every bit of it. Just to show you the rationale for getting these criteria of like slowness, weight loss, exhaustion, that type of phenotypical model to describe frailty. So due to reduced resting metabolic rate, as you can see, this reduced total energy expenditure, which lead to malnutrition, and sarcopenia, which lead to reduced strength and subsequently walking speed. So as you can see, it's a type of vicious cycle. If you don't intervene, so this vicious cycle will continue, which result in following trajectory. So a robust adult will become pre-frail, and then he will move to frailty. Then he will move to disability. Okay, so this is the expected trajectory of a frail older adult, right? So that's about phenotypical model of identifying frailty depending on 5 criteria. Okay, but that's not the only model. Okay, so there are some other models. For example, frailty index is another popular model to diagnose frailty. So here you see how many deficits a patient has out of a previously defined set of deficits. Okay, these deficits, for example, could be medical comorbidities, diabetes, high blood pressure, dyslipidemia, osteoarthritis, and so on. Could be other problems like visual impairment, hearing impairment. Okay, so you can define your own deficits basically. So they say if you can list 20 deficits at least, depending on your ethnicity, depending on your clinical clinical practice, you can use that as a frailty index, and you just have to see how many deficits an individual has out of a previously defined list of deficits. All right, so I quite like this model for different reasons. So if you look at this tower, I hope you have played this game. So Jenga blocks, so you have to take one piece, and then the other person has to take another piece. Finally the tower falls down. If you look at the tower in your left hand side, do you think it's strong or weak? The left hand side tower is pretty strong, isn't it? So if you look at the tower in the right hand side, wobbly. Yeah, it looks very wobbly, and there are a lot of missing pieces. Yes. Right? So there are a lot of deficits. Right. All right. Yes. So as a geriatrician, I quite like this model, because what I used to do is I go with a lens from top to bottom of a patient and see what deficits a patient has. Right. All right. So you can fix the missing pieces. Okay, missing pieces, then strengthen the tower. All right, that's how you intervene for a patient with frailty. Okay, to make the tower stronger. All right, so this is the accumulation of deficit model of frailty index. All right, okay, just another method of looking at frailty. Okay, so I know this could be a bit complex. We are discussing several models at a time. So just to revise, we discussed about frailty phenotype. Then we discussed about frailty index. So this is called clinical frailty scale. So I'm discussing this method because I think this is the most practical way of assessing frailty in day-to-day practice. Okay, so clinical frailty scale was quite popular during the COVID period, and we used it to predict the outcome of older patients who get COVID infection. So this clinical frailty scale goes from 1, which is very fit, to 9, which is terminally ill. So if you look at the clinical frailty score, it's just this piece of paper where they have defined frailty depending on patient's function. Okay, so if you look at number 5, where the frailty starts, so it says these people often have more evident slowing and need help in higher order instrumental activities of daily living like finances, transportation, heavy housework, medications. And if you go at number 6, moderately frail, so they need help with all the outside activities, and also they need some help with some basic activities like bathing. All right. So likewise, depending on the patient's functional state, right, because of their functional state, so we can categorize them from very fit to terminally ill. This is quite useful because it also gives you some score, a grading system. So it's quite easy to use in day-to-day practice. Okay, and also this area is quite important as well. So if someone is having cognitive impairment, so this score recognize them as frail as well. Okay, if someone is having severe dementia, irrespective of what other comorbidities they have, they might be severely frail as well. Okay, so function is not only physical function, physical and cognitive function. All right, right. I hope this clinical frailty score will be a popular scoring system among GPs and people who see old adults. Anyone who you see old adults should use the clinical frailty score, in my opinion. Right. So there are some other methods. I'm not going into details. We use in geriatric clinics basically, assessing the gait speed, doing a test called time up and go test, and using Prisma 7 questionnaire, and there are some other questionnaires we can use to assess frailty. So all these tools have its limitations and have their benefits. All right. So I'm not going into detail, just to show you that there are so many tools which we can use to assess frailty. But most important ones I think are frailty phenotype and frailty index and clinical frail scale. Right. Okay. We are going to move to another case scenario. Time? Right. Okay. Okay. So this is about a 75-year-old male who presented to accident service following a fall. So following the fall, he has hit his head, and so in the emergency department they did a CT scan, and CT scan was normal. So what happens usually is, like, if they don't have any external injuries, if CT brain is normal, the patient will be discharged. But you noted now that when the patient is getting down from the bed, he is reporting giddiness. Okay, and further he says now every day morning when he getting down from the bed, he has this giddiness. Okay, right. And going through the falls history, he has had 6 falls during last 6 months. Okay, now he is feeling increasingly unsteady on his feet, so he had to use a walking stick to help with his balance. As a result of this, he had marked fear of falling, which has reduced him moving outside the house. So he is basically homebound at the moment. Okay. So, going through the past medical history, he has diabetes, ischemic heart disease, hypertension, dyslipidemia, osteoarthritis, early CKD, and he has glaucoma and urinary urgency. So, we see these kind of complicated medical histories in older people quite often. Okay, right. Right. So, using the clinical frailty scale, where would you put this patient? So now this patient is able to carry out his basic activities of daily living, but as a result of his instability, okay, he is not moving outdoors. Okay, so he need help with outdoor activities. Yes. All right. So I would put him as clinical frailty scale 5. So he is mildly frail. Okay. Right. So further assessment. So as I have already told, these patients need further assessment. So the gold standard tool for the assessment is called comprehensive geriatric assessment. All right, it's a quite important tool. Basically, you have to look at this patient, go from head to toe, and see what kind of deficits these patients have, and then we need to make a comprehensive plan to correct these deficits to get an improvement. Right. All right, we'll see how to do this. So as I already say, I'm looking at this tower, yes, going from top to bottom, looking at the deficits and trying to fix the deficits. Okay, right. So comprehensive geriatric assessment include assessment of not only medical comorbidities, cognitive function, psychological state, nutritional state, and the drug chart, social support, functional states. It's a kind of holistic assessment. Right, so just look at this assessment for this index patient. Right, so if you look at the hearing and vision, now patient is found to have right side cataract. Right, so patient was found to be having mild cognitive impairment using a standard tool, and even though his mood is normal, he had some anxiety related to fear of falling, and he is at risk of malnutrition. I have done a test called time up and go test to see the gait speed, which is about 20 seconds, which is prolonged if it is more than 10 seconds. And chair eyes test is test used to assess the lower body strength, which is prolonged in this patient, suggesting of reduced lower body strength, probably due to sarcopenia. And if you look at the blood pressure, so at supine level, the blood pressure is 130 by 80, but it drops to 110 by 65 when the patient stands up. So what do you call this? So there's a drop of 20 millimeter of mercury from when patient stands up from lying down position. So, and diastole also dropped by 15 here. So this is postural hypertension, isn't it? So patient has postural hypertension, all right? And he has a systolic murmur, probably aortic stenosis, sclerosis. So it was not further assessed at this point. And looking at the bladder and bowel functions, he complains of some urinary urgency, for which he was put on some treatment recently. And as a result of long-standing diabetes, this patient has peripheral neuropathy. And if when I did a FRAC score, the major osteoporotic fracture was 12% and hip fracture risk was 5%. So indicating high risk of fractures following a fall. And then we did routinely do a home environmental risk factor assessment. If you look at the drug chart, so this is the patient's drug chart. So as a result of multiple comorbidities, he is on multiple medications, sometimes unavoidable. So for ischemic heart disease, now he was put on secondary prevention with aspirin and atorvastatin. Other than that, he's on carvedilol, enalapril, which are known to be prognostically giving some benefit, prevention of cardiovascular adverse outcomes. So because his blood pressure was relatively increased with low dose of enalapril, he was put on amlodipine, and at some point he had some edema, probably due to amlodipine, which was never revealed, and he was put on some HC to help with his edema and high blood pressure. So, and because he had diabetic neuropathy, he was put on amitriptyline, and for the glaucoma, he was put on timolol, which is again a beta blocker, which also can affect postural hypertension, which we usually don't consider. Eye drops as a cause of which can cause postural hypertension. And then he is on 2 hypoglycemics for diabetes, and he was put on sulfenazine for urinary urgency and a B complex because he had some neuropathy. Those are the common prescriptions. So he's on 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 drugs. So if someone is on 5 or more drugs, we call it polypharmacy. All right. And if someone is more than 10 drugs, we call it extreme polypharmacy. So this patient is having extreme polypharmacy. So as we discussed, because he is multimorbid, sometimes these polypharmacy could be appropriate, but the problem is now when a person is getting frail, they are more susceptible to drug side effects. And the other thing is, like, we need to regularly review whether these drugs have actually done a benefit. Okay, and we also need to see what patient needs. Right. Patient might want to actually go for a walk outside, right? Yes. But we are trying to prevent a second heart attack, and we are giving so many antihypertensives. So as a result, patient is developing postural hypertension. Yes. So he is not stable on his feet. All right. So looking at this drug chart, furthermore, if you can see, this patient is on 5 drugs which can affect the blood pressure: amlodipine, enalapril, carvedilol, HCT, and timolol. So this causes something called synergism. All right. So when you add an antihypertensive, a second antihypertensive, usually we expect additive effect. All right. So but actually what happens is these effects multiply. All right. So as a result, you don't get the expected effect, you get a much more effect.
Right.
All right. For example, if you prescribe NSAID, warfarin together, you expect bleeding. You even with SSRI, antidepressants, if you prescribe NSAIDs together in trained older people, there's a high risk of gastric bleeding. Okay, so if you combine two antihypertensives, so you will expect it to reduce certain degree of blood pressure, but actually they exponentially increase the risk of getting hypertension. All right, this phenomenon is called synergism. Okay, and if you look at the next example, so this is what I previously told. Now this patient had developed edema. We don't know whether it's due to amlodipine or not. I'm just putting this for sake of learning. So amlodipine can cause edema. Sometimes these patients are put on HCT to treat the side effects. So these are called prescription cascades. All right. So when you look at a patient, you have to think, now this patient is quite frail. He's on so many medications. Can we de-prescribe some of his medications? Right. So we discuss about prescription, but we often do not discuss about de-prescription. All right. So we also need to discuss about de-prescription when it comes to managing frail older adults. Okay. The other important thing I want to highlight today is like about the anticholinergic drugs we put on these patients. For example, this patient was on amitriptyline to help with his neuropathy, which is a drug which has a high burden of anticholinergic side effects. All right, and patient was put on solifenacine to relax the bladder, which also has some undesirable anticholinergic side effects. So just to highlight what is meant by the anticholinergic side effects, so they can the common side effects are dry mouth, confusion, blurred vision, urinary retention, and constipation. So are these common in old adults or uncommon in old adults? I think these are quite common in old adults. So most of the patients I see in geriatric clinics complain of dry mouth, and so most of these patients are on high burden of anticholinergic drugs. The other thing is, so as I told with antihypertensives, even with these anticholinergic drugs, the effects accumulate. All right, we basically have to calculate the total anticholinergic burden of a drug prescription. So if you are interested, you can go to Google and type ACB calculator. So where you can put these certain drugs and get a score for each and every drug and see whether how much of anticholinergic effect each drug has. For example, if you put amitriptyline in ACB calculator, it will give you a value of 3. If you put solifenacine, it will give a value of another 3. And if you put something like panadine, because it has a codeine component, it gives anticholinergic effect of 1. So if you combine all 3 drugs, you get a total anticholinergic burden of 7. So patient has a higher risk of developing dry mouth, confusion, constipation, blurred vision, and urinary retention. So we need to understand these patients are very, very fragile. You need to handle them with care. Okay, and we need to keep less stringent blood pressure targets for these patients, less stringent glycemic targets for these patients. Don't try to achieve targets as we do in young adults. We have to have some relaxed targets for these patients. So otherwise they can't tolerate it. For example, this type of frail elderly patients, I would say the blood pressure target would be 150/90 rather than 130/80.
Right.
Okay, and glycemic targets, we go for a high HbA1c value for about maybe 7.5-8% depending on patient's frailty, rather than trying to get blood sugar lower, which can result in hypoglycemia and sometimes cognitive impairment, long-term cognitive impairment, falls, a lot of other adverse outcomes. All right. Okay, so these patients are very fragile and you have to handle them with care. Okay. Right. So as you can see, When you assess a patient, a frail old adults with this type of presentation, so you need a multi-dimensional assessment, and also to get a proper outcome to prevent a fall in these patients, you need multimodal interventions. Okay, for example, now this patient has multiple risk factors which result in fall. So if you correct only the postural hypertension, would you be able to prevent another fall? No. So you might need to correct the cataract, okay, and reduce the anticholinergic burden, right, and strengthen the lower body muscle strength, right, look for vitamin D deficiency, all right, and strengthen the bones to prevent a fracture in case if he falls again, all right. So you need to do multiple interventions to get a good outcome. That's really important. So sometimes we need involvement of multidisciplinary team to achieve this target. Yes. Right? Because there are several multidisciplinary members, they are specialized in several different areas. All right. Okay. And did you know these could be common presentations of frailty as well? Now we just discussed a patient who had a fall, and similarly, if patient had immobility or sudden change in the mobility, you have to suspect underlying frailty, right? So these changes are not due to single reason, these are due to multiple organ failures, especially as a result of which patient develop frailty, and then they can become immobile and sudden change in mobility. And new onset or worsening urinary or fecal incontinence could be a first presentation of frailty, and developing delirium. And if someone is susceptible to medications, you have to suspect frailty. And if someone is showing delayed recovery from an acute illness, you have to suspect frailty. And if someone is having frequent hospital admissions with functional decline, you have to suspect frailty. So if you only correct the presenting complaint, it doesn't reverse the trajectory. Okay, the next time patient will come with another complication of frailty. Okay, right. So same thing I'm showing in this diagram. So there are some diseases where the risk factors cause early disease and then it moves to late disease and so on. But if you move to the third model where multiple risk factors interact with each other and they all contribute to cause one result, this is called interactive concentric model, which is the one we use to describe geriatric syndromes and frailty syndromes. Okay, just to highlight again how this multifactorial nature of geriatric syndrome. So if you look at a fall again, so there are a lot of intrinsic factors and extrinsic factors which can result in a fall. But often one patient has multiple factors, not only one factor. Okay, so that's what I was highlighting in previous slide, that you need to correct multiple deficits to prevent a fall. And if you look at delirium, it's the same. So there are some predisposing factors, there are some precipitating factors, and there are some continuation factors. You need to consider everything and correct all the factors to treat delirium. And urinary incontinence is the same. Okay, so it's not just due to overactive bladder. So it's an interplay between patients' age-related changes in the urinary tract and patients' medications and patients' comorbidities. Yeah, just to highlight how complex the assessment of urinary incontinence is, these are the age-related changes you see in the older person. I don't expect you to go through everything, but just to show how complex this can be. So all these comorbidities has an effect on urinary incontinence. All these drugs has effect on urinary incontinence. So they develop urinary incontinence as a result of multiple factors rather than one single factor. That's why these patients need comprehensive geriatric assessment, head-to-toe assessment, going through their drug charts, simplify the medications, and do appropriate interventions to treat the frailty. All right. So what further interventions we can do to frailty rather than doing a comprehensive geriatric assessment and correcting the deficits? So as you can see in this diagram, so this is called the domino effect. All right. So the first block falls on the second one and so on. And so these patients, if you don't correct, So they will go through the same trajectory until they develop a disability. So what can we do other than doing comprehensive geriatric assessment and correcting the deficit? So people have again go into researchers to see what type of interventions we can do to help with frailty, and in addition to comprehensive geriatric assessment. So it has been shown that exercise prescription is quite a good tool to prevent frailty and treat frailty as well. So out of all the exercises, the resistance exercises has more benefits, right? So do we often prescribe resistance exercise to older people? We don't, and sometimes it might not be practical, but sometimes so there could be opportunities to prescribe resistance exercises, and we should consider that as a way of preventing or treating early frailty. And the other thing is having good nutrition. So it has been shown high protein intake up to 1.5 grams per kg per day, especially combined with resistant exercises, can reverse frailty. And other than that, if someone is vitamin D deficient, treating vitamin B deficiency and can potentially reduce frailty. Okay, right. And what are the pharmacological interventions we can do? Are there any any pills which we can substitute to comprehensive geriatric assessment, nutritional and exercise interventions? Because all those things are very hard, isn't it? CGA takes a long time. Sometimes giving high protein might not be very practical, and doing resistance exercises might not be sometimes very practical. But unfortunately, at this point, there are no medications actually proven to reduce frailty. So drugs like AC inhibitors and some amino acids like leucine and testosterone and growth hormone and a drug group called myostatin inhibitors is being studied, but at the moment there are no universal recommendations on drug treatment to reduce frailty. Other than for hypogonadism, you can give some testosterone. Right. Okay. So we saw this slide before as well. So these patients with frailty follow this trajectory where robust individuals become pre-frail, they become frail, and they become disabled. So is there any opportunity to intervene? Yes. Yeah, this happens very slowly over time. So you have multiple opportunities to intervene. So the other thing is we can reverse frailty sometimes. So you can make a pre-frail person sometimes less frail. Okay, you can make an early mild frail person pre-frail by doing appropriate interventions. So potentially you can change this trajectory, change this course. Okay, that's why it's important to, in your clinical practice, suspect frailty and detect frailty and do appropriate interventions to reduce the healthcare burden, to reduce this, to stop this trajectory. Okay, right. So with that, I'm moving to another case scenario. Right. Okay, do we have time? Yes. Yeah, all right. So this is about 89-year-old female with advanced dementia. So this patient was admitted to the medical ward with a third episode of aspiration pneumonia in the last 3 months. She was completely dependent for personal care for last 3 months and not able to recognize family members. And despite initial course of antibiotics, she is still having ongoing oxygen requirement, and now her blood pressure is falling. All right. Yes. So basically, this patient is advanced dementia now, who was bedbound, yes, now developed probably aspiration pneumonia. It sounds like she's developing recurrent aspiration pneumonia. So you're treating with antibiotics, and but patient is going to septic shock. Okay. Right. So looking at the clinical frailty scale again, now we are talking about a completely dependent patient, and probably as a result of severe infection and frailty, now she is approaching her end of life probably. So I would categorize this patient as category 8 in clinical frailty scale. All right, very severely frail. So what would you do to this patient? So there are several options. Okay, so now this patient's blood pressure is dropping, so you need to do something. Do you consider ICU admission? Do you consider ward-based care with inotropic support? Now the antibiotics are not working. That's why the blood pressure is dropping. So would you consider repeating blood cultures and escalating antibiotics? And look for an alternate source of infection? Because we are treating for chest infection, it could be something else. Or would you consider discuss the prognosis with the family, aim comfort and dignity as she is reaching end of her life? So think about that. So all these options are possible.
Yes.
Yeah. So, but what do you think is most appropriate here? To help with taking decision regarding this type of patients, I'll show you the trajectory again. All right. So this is the expected trajectory of decline in older people with frailty. Okay. So now, when you get acute illness, you go down from your functional baseline, yes. Right? And as I already discussed, they recover, but they don't go back to their previous function. They come to a new baseline, slightly lower than their previous function. And over time, what happens is you get more insults, yes. All right? And they go lower and lower. Step down. Yeah, in their function, and finally they reach end of life. Okay, yes. So this is the expected trajectory. Okay, so do you think with the best possible treatment, I mean, if you want to put this patient to ICU, if you want to give this patient iron drops, higher order antibiotics, would you be able to make this patient walk again? No. So you have to look at the baseline. So baseline, this patient was dependent for personal care for last 3 months, and she is unable to recognize her family. Okay, and she is bedbound for last 3 months. So even with whatever the treatment you do, so you expect this patient to go down from her previous baseline. All right. So especially with this severe infection, the high chance of patient is reaching the end of life. Sometimes we need to understand this is a natural trajectory of frailty and old age. Okay, this is not a medical failure that patient is at the moment not responding to antibiotics. Right. So these type of trajectories are very useful to predict outcome and do something called advanced care planning. So just to decide on what treatment we should offer this type of patients, okay, and to recognize end of life and dying phase. Okay. Right. I think this patient who developed recurrent chest infection as a result of aspiration, probably due to severe dementia and sarcopenia, which are not reversible at this stage. So if you treat this patient and go home, there's a higher chance patient will get another chest infection in the next 2 weeks, and which result in another hospital admission. So we need to discuss the prognosis with the family and come into an agreement about the plan of action. But make sure you address the patient's comfort and dignity as well. Okay, just one slide about frailty in critical care settings. So before admission to ICU, we need to look at the patient's clinical frailty scale to see what kind of functional baseline patient has to decide on possible outcome, because there had been extensive studies actually done on frailty and outcome after critical care admission. It has been shown, so it has a good value on predicting a patient's outcome after ICU admission. Even a patient who is being treated in ICU or being discharged from ICU, it's very important to understand how frail this patient is and what deficit patient has to decide on the further actions. All right. So there's a very nice tool created by the Sri Lanka Association of Geriatric Medicine on frailty care. This is kind of a frailty care pathway. So this is the link for the frailty care pathway, which you can use your day-to-day practice. Okay. Right. So we are coming to the end of our presentation. We have some time for the questions as well. So I want to highlight some take-home messages at this point. Early recognition of frailty and early intervention can potentially change the trajectory of disease in older people. So you need to identify frailty at an early stage and do comprehensive genetic assessment and appropriate intervention to change the course. And clinical frailty scale, as I told, is very easy tool to use in clinical practice, and we all should get familiar with clinical frailty scale. Especially we are looking at next 15 years where we would see more elderly patients in our clinics. 1 in 4 will be an older person in our community. And comprehensive geriatric assessment is the way forward for the assessment of these complex multimorbid patients, and we need to correct multiple deficits. We need to strengthen the tower and do multimodal interventions to treat these patients with frailty. And don't forget that we need to handle these patients with care. They are very fragile. You need to, if you start a new drug, see whether you can de-prescribe a drug before starting a drug, okay? And start from the slightest dose you can do and gradually titrate the doses and see the response. All right. Thank you very much. I think we have time to get some questions from the audience.
Thank you so very much, sir, for that excellent lecture. It was very eye-opening. I think it's a branch of medicine scarcely discussed, but very often come across during our first contact practice. And the way you described it and how you brought all the aspects to us was very interesting, and I should thank you for that, sir. And I think we are getting a question at the moment. So if a patient with CKD with BP 150 is enough?
To answer that question, actually, so don't take home the message that we need to, that we can keep 150, 90 for all the patients, actually. So it depends on patient's clinical frailty scale and the stage of CKD and what your treatment goal is. So usually for patients with CKD, and especially if they are comorbid diabetes, we tend to keep blood pressure as low as 130/80. So, but I mean, if someone is more frail, if they develop postural hypertension or the side effects of medications, if they are very frail, then we have to get into a kind of evaluation and decide whether we can have a less stringent target. So it's possible to keep less stringent target for older patients with frailty and multimorbidity like 150/90.
The next question, sir. What is the latest evidence of vitamin D in frailty?
Yeah, so again,
can we prescribe vitamin D?
Yeah, so again, very good question. So there are a lot of doubt about vitamin D in clinical practice. So if someone is vitamin D deficient, okay, if someone is vitamin D deficient, it has been shown that it worsens frailty. So replacing vitamin D is quite good intervention to reverse frailty. And the other thing is, when you prescribe vitamin D, you also need to understand, you need to prescribe a loading dose before you give the maintenance dose of vitamin D. So there are several methods of doing that. Actually, I used to prescribe vitamin D 60,000 international units weekly for 5 weeks, just to prescribe somewhere around 300,000 for a vitamin D deficient person, and then prescribe daily requirement of vitamin D. So again, if patient doesn't have any sun exposure, if patient is having high risk of fractures, I would go for a vitamin D dose of about 1,500 to 2,000 units, international units daily, which is the kind of daily requirement. So again, it depends on patient to patient what daily requirement is, but don't forget loading the patient's vitamin D level before you give the daily requirement.
That means we should go for the loading doses, as you mentioned, around 60,000 international units for 5 weeks, and then go for the daily dosage?
Yeah, so I tend to continue the daily dose as well as
the loading dose.
Yeah, loading dose.
Right.
Yeah. So there are several methods of loading vitamin D as well. So some people use 40,000 international units weekly for 7 weeks. The principle is you need to replace somewhere around 250,000 to 300,000 before you give the daily requirement.
Right. So vitamin D is a hot subject. So then they are asking, can we give vitamin D without deficiency?
So if you suspect your patient is not getting enough sun exposure, and if patient is having risk of falls and fractures, then of course you can give vitamin D.
Right.
And don't forget to monitor calcium in, not very frequently, but the slight risk of developing hypercalcemia if you give vitamin D for every patient not monitored. But most of our patients, especially older patients, they are housebound and they don't get any sun exposure. And so it's appropriate intervention to strengthen the bone health and muscle strength as well.
Right. So another question, can you please explain calculation of frailty index again?
Yeah, okay. All right. So I'll go back to my previous slide. I'm very happy to see people have actually listened to the slides. Very good. Okay, so frailty index is basically, so you should have a previously defined list of deficits. Okay, for example, so this is basically mainly used in research. Okay, where we measure frailty usually using a standard database. For example, I want to see how many frail patients I saw were admitted to the hospital for last 1 month. So I go through patients' records and see how many of these patients had diabetes, hypertension. Likewise, I made a previously defined standard list of deficits and then see each individual how many deficits do they have. Right? The clinical implication is, as I said, now if you look at this model, so this explains when you have accumulation of deficits, right, the tower become very weak. So similarly, when you accumulate so many deficits, these elderly patients, they become frail. So knowing what deficits they have is important as a measure of strengthening the tower or like planning your intervention. So that's why the clinical frailty index is quite useful way to detect frailty. So, but often this method is used in research rather than clinical practice. So, most often we use clinical frailty scale.
Right. So another question: lifelong testosterone to a non-hypogonadal person has benefits to prolong life. It's a question.
No. So there are no consensus of giving testosterone for older people without hypogonadism. So answer is no.
Answer. For as a diagnostic tool during GP practice or first contact practice, can you use this 9 points, the clinical frailty scale?
Yes, definitely. I think we should do it in our day-to-day practice.
Right, yes. Sir. And that's all with the questions, sir. And I should thank you again and again for bringing forward this specialized branch of medicine towards us. And I'm sure we all can witness that everyone is very much interested in this field. As I first mentioned, that it's scarcely discussed, but we come across such patients more and more during our clinical practice. So we expect that you'll be kind enough to grace us with another such session in the future. And thank you so much, sir, and wish you all the very best.
Thank you very much. Thank you.